So we are going to cover the urinary system. It's a relatively simple system from the anatomical point of view, but it offers several aspects that have to do with physiology. So you need to pay attention to those aspects because they will prepare you to understand physiology. So let's have here an overview of the system. So you can sit here for a while and try to see the different portions of the urinary system and have an initial view of what they are responsible for. A good way to see it as will be the kidneys as producing urine. That urine is travels into the urinary bladder in the ureters, and then out of the urinary bladder in the urethra. So let's start with the kidney. So the kidneys are bean shaped organs, essentially retroperitoneal. So if you look at them for their relationship with the ribs, you see that the right kidney reaches a little bit below, and that has to do with the space that the liver takes up on the right side. And to look at it from a different anatomical perspective, understand that the relationship between the kidneys and the back. So kidney problems may elicit some back problem in the sense they are so close to the back muscles. The kidneys have a fibrous capsule. Then there is fat tissue around the kidney. It's called the perinephric fat. And there is fascia, the renal fascia, surrounding that space. So now that we know the anatomical relationships of the kidney, we can actually start looking at the kidney and the kidney structure. So you see the kidney here divided into a cortex, that is an outer area, and the inner portion, which is the medulla. Like other organs, where all the vessels, and in this case the renal pelvis is, we call this the hilum. So all this will have a very important and a correlate in terms of function, which is trying to keep this in anatomy. So now, if you look at the medulla, you can see the pyramids. So you have the medullary pyramids, and you see the bases of the renal pyramids. Are directed outward, and the tips or the apex of the pyramid are inward towards the area that is called the renal sinus. So the apical projection of the renal pyramid is called the renal papilla. So see that each renal papilla drains urine into a minor calyx. Minor calyces drain into a major calyx, and 2 or 3 major calyces will form the renal pelvis. the renal pelvis continues as ureter. So this is the macroscopic anatomy, but the functional unit of the kidney is the nephron. So we can we can assess the function of the kidney by the number of nephrons that are working. We lose nephrons with age, for example, and therefore our kidney function declines with age. A nephron has an interesting anatomy that is very important to understand the physiology. So we have a portion that is a renal corpuscle, and then a tubular system. The renal corpuscle has a capsule and a complicated collection of capillaries they call the glomerulus. So the glomerulus is inside of a capsule, and so the blood is filtered. Filtration is the process of the blood, of content of the blood flowing out of the vessels. So the blood is filtered, releasing fluid out into the Bowman's capsule. That's a process that's called filtration. We normally just see the situation as far as nephrons, but in fairness, there are separate, different kinds of nephrons depending on their location. So some nephrons, the majority of them, they are mostly on the cortex, in the kidney cortex. Those are called cortical nephrons. A minority, around 15%, are just the medullary. So these will be nephrons in which the renal corpuscle is in the junction between the cortex and the medulla, and the longer portion of the nephron actually is in the medulla. So let me show you this in pictures because it's better seen this way. So you see a cortical nephron and just a medullary nephron. Okay, so we are still on the overview, and to finish this overview, let me talk about the renal blood supply. So we have two renal arteries and then two renal veins, the left and the right. But now we can start speaking a little bit more in detail. Is that normally an organ has an artery that branch into small arteries, and the small arteries branch into arterioles. The arterioles branch into capillaries, and the capillaries would merge into venules, and then venules, small veins, and so on and so forth. The situation is not exactly like this in the kidney. So the renal artery will have that trajectory all the way up to what we call an afferent arteriole, so different afferent arterioles, and then the glomerular capillaries. But now the glomerular capillaries, instead of forming a venule, they will form a second arteriole. It's called the afferent arteriole. And the afferent arteriole branches into peritubular capillaries. And these peritubular capillaries will then follow the trajectory into forming venules that will eventually will drain into the renal veins. So the system is done in a way that you can see it a little bit like here. Its image comes from your textbook. So it's not very important to know the intermediary steps, but this idea that the renal artery branches and forms the afferent arteriole, which gives off the glomerular capillaries, and they merge to form an afferent arteriole, which gives off the peritubular capillaries, which then will merge to form to drain into the venous system, is very important, because we have essentially the glomerulus, which is the place where filtration occurs between an afferent arteriole and an afferent arteriole. So the way we regulate filtration, it will be by opening or closing more the afferent arterioles or the afferent arterioles, because by changing the dilation of these arterioles will change the pressure inside of the glomerulus. The greater the hydrostatic pressure in the glomerulus, the more it will come out more fluid will come out of the capillaries. So the more is filtered. So we call that pressure the hydrostatic pressure. Again, concepts that you will fully expand when you go into physiology. So let's now look at the specifics. You pause here, pause as you see fit, and then we'll go into the specifics. We mention everything. Now we just need to go add more details about the glomerulus, and then speak about the tubules. So here we have the Bowman's capsule and the glomerulus. So pay attention to this anatomy, and I'll have several slides to make sure we go very slowly about it. The capsule has two layers, a visceral layer and a parietal layer. The parietal layer lines the capsule on the inside, and the visceral layer is going to line the capillaries and has these processes that are called the podocytes. So the podocytes sit on top of the glomerulus. So now if you are a substance inside of the glomerulus and you want to come out, you have to pass the space between the endothelial cells and then the space between the podocytes. I'll show you this in a little bit, because there is actually a third element that we need to cross. So you can analyze the corpuscle as having a vascular pole and the tubular pole. The vascular pole is where the afferent and the afferent arterioles are, whereas the tubular pole is where the proximal convoluted tubule connects. So we filter out, we send the fluid out into the capsule, and now the fluid, which is called the filtrate, is going to flow in the proximal convoluted tubule. I wanted just to mention a couple of things that you see there, although I have a slide to mention that. In that vascular pole, you have a justoglomerular apparatus that has, among many things, the mesangial cells and the macula densa. We'll mention that at some point. I have a better slide for that. It's important for different physiological aspects, so let's just keep that in mind. But I'll have a next different slide in which I'll call your attention for this again. So as much as as much as we are not going to cover all the details of physiology, it does help adding some details. So this is what we can see, and in using the electron microscope to look at this, all that space that a particle needs to cross to be filtered. So the inside is to your left, so you see the space between the endothelial cells, then it needs to cross a basement membrane, and then it needs to cross the space between the podocytes, which are called the filtration slits. See that the glomerular capillaries, in the glomerular capillaries, the endothelial cells have spaces between them. This is what we call a fenestrated capillary. So this is very important, and all these structures form what we call the filtration membrane. So in the diagram here, the endothelium, which is fenestrated, the basement membrane, and the visceral layer of the glomerular capsule, which are the podocytes. So a different view. So you can never accuse me of not preparing you fully for your physiology. What may happen is that by the time you get there, you already forgot this component. So the endothelium is fenestrated, then I have to cross the basement membrane, and then I have to cross the space between the podocytes. So there is here, as you can see, a limitation in terms of size. So only smaller substances can be filtered. So you don't expect cells to be able to be filtered, to be able to cross from the blood into the capsule. Only small particles. But also, you'll learn later on that the basement membrane is negatively charged. So another factor to add to this selectivity will be the charge of the basement membrane. And so you can, I have these 3 slides because they're very, very important for physiology, and not only for physiology, to understand the pathophysiology of the diseases that affect the glomerulus. I promised you a slide in which I mentioned the juxtaglomerular apparatus, and you see here the different components: the macula densa, which is part of the distal convoluted tubule, the extraglomerular mesangial cells, and the juxtaglomerular cells. The juxtaglomerular cells are the cells that produce erythropoietin, EPO. And so this system you'll speak a little bit more also when you talk about renin, angiotensin aldosterone. That is important to control the blood pressure. And that's pretty much the anatomy of the glomerulus. So if you have a little bit of time, I would suggest adding a little bit more of physiology, expanding a little bit, not fully go over physiology because maybe you don't have that interest, but just read a little bit more. It helps at least to organize the thoughts. I have a short video that will help you at the end too. The renal tubule is named after the different portions. So there's a proximal portion and there's a distal portion. So before we go into the naming, I just want to explain the physiology. So we filtrate it, and now we need to reabsorb, and the tubules will reabsorb in the sense that it will call back substances that were filtered, but they can also even send more substances into what will become the urine, which is secretion. So filtration is from the glomerulus into the Bowman's capsule, and then the reabsorption and the secretion are selective processes, meaning that are more selective than filtration because we have specific transporters, specific channels that allow either reabsorb, call back substances, or secrete, send even more substances into the fluid. Remember, this fluid is what will become urine. So we can look at the process of reabsorption and secretion to be very, very unrefined in the proximal portions, and to be relatively more refined in the distal portions. I have a slide with this, so if you didn't catch this right away, I'll show you in the next slide. So this is the anatomy. So you have the proximal tubule and the distal tubule and the loop in between. The proximal tubule, we oftentimes call it proximal convoluted tubule. The distal tubule, we call it also distal convoluted tubule. And the nephron loop is in a more classical anatomy called the Henle's loop. It's spelled out in a different slide. Each nephron produces then urine that is collected by a collecting system. The collecting system has connecting ducts to it, and then it consists essentially of the collecting ducts, and then there will be papillary ducts, and eventually the papilla drains into the minor calyx. So it's somewhat like this. So there's filtration in the glomerulus. In the proximal tubule is a coarse reabsorption. In the distal tubules, collecting ducts, the reabsorption is more refined and oftentimes adjusted to the needs of the body, meaning that a lot of hormones will act there. So when I mean physiology, you could this is a good slide for you to begin understand what happens in each portion of the tubules and the glomerulus. Just show you the microscopy of it. And to fully give you the full aspects that allow you to understand physiology, I want to repeat the capillary system around the nephrons. I want you to understand that afferent gives off the glomerular capillaries, will join to form the afferent, and the afferent branches into peritubular capillaries. See what filtration is: movement of substances from the glomerular capillaries into the Bowman's capsule, and then there are two possible movements. Number 2 is sending back to the blood, that's reabsorption. Number 3 is secretion. And to fully understand this aspect, so the arterioles, the afferent and the efferent, regulate the hydrostatic pressure. The higher the hydrostatic pressure, the higher the filtration. So this, I think it's already a good combination of physiology and anatomy that will allow you to memorize better anatomy but simultaneously prepare you for physiology. Show you a video of a functional overview.
The mammalian kidney helps regulate water balance and removes waste from the blood. The functional unit of the kidney is the nephron, which consists of the glomerular capsule and a long twisted tubule. Each human kidney is about 1 million nephrons. Blood flows through a twisted capillary bed called a glomerulus, which is surrounded by the glomerular capsule. Blood in the glomerulus is under high pressure so that water and various small molecules leak out through its porous walls and move into the capsule. This liquid filtrate contains many valuable molecules, as well as a great deal of water. As the filtrate moves through the tubule, nutrients such as glucose and amino acids are transported back into the bloodstream. Some substances, like calcium and potassium, are secreted into the filtrate across the tubule walls. Most of the water returns to the bloodstream as the filtrate moves through the collecting duct. Urine travels from each kidney to the bladder through the ureter.
Okay, so this I hopefully played well. The sound, or not so bad, but it gives you a nice functional overview. But we have all that in the slides. So now let's go to the last portion, which is relatively simple. So the urine is formed, and we have the ureters. The ureters transport the urine into the bladder. And there's not much to know about their anatomy, although I would like you to know two things, which you already know. One is the epithelium, so this is a transitional epithelium. And two, there is some smooth muscle. In the ureter. And here to show you that, so I just want you to really know that there's smooth muscle there, so there's possibility of contraction of the smooth muscle. And then I want to show you the transitional epithelium, which you know that is particularly important to allow certain dilation, a certain expansion of those cells, but also for resistance. When the ureters reach the urinary bladder, they open in what we call the ureter orifices or openings. They enter an area called the trigone. And that's pretty much what I wanted you to know, what is necessary to know about the ureters. Now let's move to the bladder. And let's just spend some time with the anatomy of the bladder. So if the bladder is full, it's big and it's really, you can palpate it. But when it's empty, it's really in the pelvic cavity. For example, if someone needs to do an ultrasound of the urinary bladder, they are normally asked to drink water and not to void the bladder so that we have access to the full bladder. The empty bladder is really behind the pelvic cavity. Some people, if you, in a different kind of anatomy, we can discuss more the full anatomy of the bladder. So we can speak about an apex, a base, and a superior surface, and two infralateral surfaces. And then the neck of the bladder. So let me just show you a little bit what the difference between male and female. So in males, the base of the urinary bladder is between the rectum and the symphysis pubis, but the base of the bladder is inferior to the uterus and anterior to the vagina. So we spoke about that when we talked about the reproductive physiology. So these anatomical relationships are important to understand how masses of the uterus, including pregnancy, can compress the urinary bladder and force the person to have to use the restroom more often. Let's look at just the microscopic anatomy of the urinary bladder. And it has the same epithelium, but I would like you to know that it has the smooth muscle. The smooth muscle is the detrusor. And I'll show you in a little bit how the micturition occurs. And we are following this pathway, so you can pause here or you can continue. And we are now at the level of the urethra. The urethra is different between biological sexes, so we have a much shorter urethra in females and a longer urethra with a different trajectory in the males. Let's see the difference better. So in women, the urethra is short, around 4 centimeters long, and will open between the labia minora and the vestibulum. You see here the representation of the urethra. You see that skeletal muscle outside of the urethra, part of the perineum muscles, called the external urethral sphincter. In a different representation, again, the external urethral sphincter is smooth, it's skeletal muscle outside of the urethra, but there's also circular smooth muscle inside, which is the internal urethral sphincter. In the case of the male urethra, we have much longer. It can be divided into portions depending on where it is. So there is a prostatic urethra in the prostate. So this is important. It's a clinical correlate here, because if a person has a prostatic problem in which the prostate gets bigger, it may compromise the urethra, and so the man will complain that he has difficulty starting urinating, the micturition, or the stream of the stream of urine is not as it used to be. Then there is a membranous urethra, and then there is a spongy portion of the urethra that should open in the external urethral orifice. Normally this is at the tip of the glands. There are anatomical variations that may be needed to be corrected. So let me just show you here the representation for us to look at the internal sphincter and the external sphincter. The internal urethral sphincter is smooth muscle. The external urethral sphincter is skeletal muscle. As far as the micturition, I just want you to really know the basics of this. So there are sympathetic and parasympathetic inputs, and there's also the somatic control of the external urethral sphincter. So this is the representation, the pattern of innervation. So you have the sympathetic, the parasympathetic, and the pudendal. And the actors will be the detrusor, the external urethral sphincter, and the internal urethral sphincter. So during filling up of the bladder, this is sympathetic. The sympathetic relaxes the detrusor and contracts the internal urethral sphincter. So it's a fight or flight response. There's no time to use a restroom. During micturition, so when we're avoiding the urinary bladder, we have inhibition of the sympathetic, and we have activation of the parasympathetic by contracting the detrusor and relaxing the internal sphincter. So note that there are things get a little more complex in the sense that we have stretch receptors that are detecting how stretched the urinary bladder is being, and then initiating the contraction of the detrusor. So in both cases, we can also act on the external urethral sphincter. The external urethral sphincter is contracted during filling up, but during micturition, if the time is right, the external urethral sphincter needs to be relaxed. So let me just show you a picture here. So you have the detrusor, the internal urethral sphincter, the external urethral sphincter, So there are also stretch receptors that will be important to initiate the reflex when the bladder is filled up. But as far as the three protagonists, the parasympathetic, the sympathetic, and the somatic motor, we can organize it this way. So the parasympathetic contracts the detrusor and relaxes the internal sphincter. So in that sense, is more active during micturition, so we're avoiding the urine. The sympathetic is the other way around, relaxes the detrusor, contracts the internal sphincter, and therefore is more active while we are filling up the bladder. And the somatic is essentially important to relax the external urethral sphincter when during micturition. Okay, and so we finish this portion here.